Good morning, everyone. Welcome to the Shiley Eye Institute. We're very pleased today to host the symposium, Thyroid Eye Disease from Start to Finish. This seminar is being co-hosted by the Graves' Disease and Thyroid Foundation, and we welcome all you here in the audience and also welcome to our internet viewers. Many of our patients do undergo a long journey with thyroid eye disease. It involves many years of treatment and surgery, and the goal of today's seminar is to update you on the latest techniques. We've assembled a panel of physician experts, and also we have patients that are going to share their experience. So without further delay, I'd like to introduce the first speaker, Dr. Bobby Korn, who is an associate professor here in our department. He will be speaking on the ophthalmic manifestations of Graves' disease. Dr. Korn?
Great. Thank you very much, Dr. Cacao. Well, again, I want to iterate Dr. Cacao's thanks. Thanks very much to the Graves' Disease Foundation for sponsoring this seminar. But more importantly, thank you for every one of you patients here who are here, dedicating your Saturday morning to hear about us. And not only just, hearing us spout all this wisdom and all these things that we may know, but really for you as your role as our teachers. When we read and go through medical school, we read about all these symptoms that, patients go through, but when you actually see patients go through this themselves, it teaches us so much more. So thank you for teaching us all that you've done over the years as patients and making us as better clinicians. I'm getting over a cold, so apologies for my crackling throat here. Okay, so let's just start with the basics here. What is Graves' disease? Well, there's several different names for this. Thyroid eye disease, thyroid-associated ophthalmopathy, thyroid-related orbitopathy, Graves' disease. It's sort of confusing. And the first thing when patients come into our Thyroid Eye Center here at the Shiley Eye Institute is that we spend time to educate them on what the actual disease is like. And this diagram here really carefully illustrates that. And what we understand is that it's actually the immune system that is the cause or the source of the disease. It's not the actual thyroid itself here that is attacking the eye. And the contrary, or the corollary, it's not that the eye is attacking the thyroid. So the immune system here is sort of the central component. And many times patients think, oh, if you remove the thyroid, then all of a sudden the eyes will be better. And usually that is not true, although there is some data to suggest that if the thyroid is altered in some way, it can have some effect on the eye. Well, certainly we can't remove the eyes. If we do that, thyroid eye disease will go away, but you'll defeat the purpose of being a patient here. So I want to sort of go over some of the steps here and talk about some of the manifestations of the disease and sort of give it to you in real terms. So how does thyroid disease affect you? Does anyone here have burning or pain in your eyes? Raise your hand. All right, a couple of hands go up. How about redness? All right, tearing? How about double vision? How about your eyes bulging? All right. Now this next one, social withdrawal. You read about this in textbooks, but you really don't understand what this means, right? And when we describe all these symptoms to our patients, we show them pictures of before and after results. Oftentimes the first response is they start to well up, they start to cry because they've sort of kept this pent up for so many years and no one has really said that there could be something done for them, right? And it's sort of a relief that, that something can be done. And, today as we go through all the different talks here, we're going to hear all the different experts talk about the different techniques that we can do to bring you back as close to normal, right? Depression, personal interactions, at the workplace, the list goes on and on and on, and it affects everyone in this room here. Proptosis, or eye bulging. What do patients feel? Squeezing, pressure. I feel like my eyes are popping out of my socket. Has anyone ever heard this? Yes, right? Tears are running down my cheek. People look at you, they're grabbing you a Kleenex. Oh, is there something wrong, No, my eyes are bulging, they can't close. I mean, I see patients here just, dabbing their eyes and, it's annoying. Just imagine if you're at a job interview, right? You're trying to talk to someone and all of a sudden tears come down your cheek, right? I had a patient who was a young law graduate. She just passed her bar exam, but for years she couldn't get a job. And, she finally came in to our center, got treatment, got her eyes back in, and her tearing stopped. And within a week, she got a job. And I said, what happened? She said, every time I went to my potential firm to apply for a job, I'd be okay for about 5 minutes, then tears would start coming down my eyes, right? And they thought, oh, you know, this is probably an emotionally unstable lawyer. We don't want this as a potential partner or office, okay? But this is how it affects you. And you can't read about these in the textbooks. This is what, you know, we need you as patients to teach us, to, you know, to make us better clinicians. So here's a little diagram. I'm not going to make this too medical, too scientific. I'm not going to show you any gory pictures or anything, but let me just give you some brief sort of basic science here. So this is a picture of a CT scan, okay? And this is basically an image that you get of your eye sockets. And anyone who's had an orbital decompression will know that you've had this scan done. It's where you sit in a little bed and all these little coils spin around you and it generates a three-dimensional x-ray of your eye socket. So on the left here is what we call an axial scan. It's as if you're looking straight down from the top of your head straight down. Here is the right eye, here's the left eye. This next view is as if you're looking straight ahead, okay? Does anyone know who this person is right here? Oh, everyone picks that up immediately. Yes, this is George. He, unfortunately, was not a patient of ours. He does not have the condition, all right? But this is a coronal view where you're looking at the front of the patient here. So here's the right eye socket and the left eye socket. And in the pre-disease or pre-grave state, the muscles, which are these little tiny strips here, there, and these four here are normal in size, okay? This white little cable here and this central sort of circle here is your optic nerve. That's the cable that connects your eyeball to your brain. That's a very, very important cable. Anything that happens to that cable can affect your vision, okay? So here's what happens when the disease becomes more manifest. You get massive enlargement of the fat behind the eye sockets, deposition of other materials within the muscles themselves, and look at what happens here to the muscles here. They get really large compared to their pre-grave state. You get more fat that expands behind the eye, and it actually pushes the eyeball out. Here is this white here is the bony eye socket. So if you put your fingers here, right on your two eye sockets here, when the condition gets very bad, your eyeball actually sticks out beyond your bone here, okay? And if you look at it here on the frontal view or the coronal view, you can see that the muscles, which are normally these tiny little strips here, get massively enlarged there. And what does that cause? It causes your eyes to bulge out. It can cause double vision. Your eyes may not move in synchrony. Double vision. Does anyone have double vision here? Okay. So this is a patient with single binocular vision, okay? This is double vision. Imagine trying to drive down I-5, 65-mile-an-hour limit with 85-mile-an-hour cars zipping by you. It's pretty hard to see, okay? And a lot of our patients will close one eye, they'll put a piece of tape over their eye. I mean, you live with this, okay? And you know, later Dr. Granite will talk to you about some of the magic that he can do to straighten the eyes out. Eyelid retraction, okay? This is another common thing that we see in this condition. Eyelids are pulled up. At night when you try to go to sleep, this is what happened. This is why you get that redness and irritation in the morning, right? Your eyes aren't closing. They're not blinking. They're drying out. And in the morning, you put a drop in your eyes burn, right? It's sort of like putting, you know, like acid on your eyes. That's why we always tell our patients, put lubricating ointments, teardrops in your eyes before you go to sleep so you can maximize the moisturization of your eyes. Optic neuropathy. This is sort of the worst thing that can happen, and unfortunately, this is not a very common condition, but I know patients in this room who've had this, okay? So what happens is that cable that connects the eyeball to the brain, the optic nerve, can be affected by the eyes being pushed out and the muscles getting so big to the point where your vision starts to dim. You're looking at colors start to look faded, pinks are no longer very pink, you know, reds are no longer red, yellows are no longer very yellow. How does that happen? Well, let's go back to this picture here. So look right here, okay? Imagine here that these muscles here get so big here that they start to squeeze on the optic nerve. If you look up here, see how much room the optic nerve has here to move? Well, as these muscles get bigger and bigger, it squeezes on the optic nerve here. Okay, so what can we do? All right. Now, you know, after we meet our patients for the first time, show them pictures and tell them what we can do, patients need to say immediately, sign me up immediately. I want this done tomorrow, right? And the unfortunate thing is that we've got to wait, okay? And waiting is often the most difficult thing that we do as clinicians here at the Thyroid Eye Center. Why do we wait? Well, this is a curve called Rundle's curve, and it actually describes the disease course of many different diseases, and thyroid-related eye diseases follows the same curve. And what you can tell is, as time goes on here from left to right, the disease gets worse, peaks a little bit, and then improves to a certain degree. And then there's a period of gradual improvement. Now, it doesn't often get back to the pre-Graves condition, okay? But this time frame is variable, and on average can take about a year. That's why when you come into the clinic, we ask you to bring photographs, old notes, so we can document when these symptoms began and when we can start the clock for starting treatment. So the bottom line is we don't want to hit a moving target. Just imagine if we intervened at an earlier phase and you're still continuing to worsen. So this is the overall approach to the treatment. It's a 5-step plan. We start first with medical treatment. If patients have severe double vision that is intractable, we can use prisms. We can even use Botox. And you think Botox for wrinkles? Well, actually, the first FDA indication for Botox was actually for the use in double vision, okay? Then we proceed with bringing the eyes in through an orbital decompression. Sometimes we will not follow this orderly step, and that's if a patient develops optic neuropathy. In that case, we're not going to wait a year for you to go blind. We're going to intervene sooner, okay? Once the eyes are back in the position, then the double vision is repaired, and then finally we take care of the drooping eyelids, the extra skin, the eyelids that are pulled up or pulled down, okay? Conservative management. Artificial tears, these should be your friend. Use the preservative-free variety if possible. Some patients, because your eyes are open, you tape them at night to create more moisturization. Steroids. We often get asked this question, and we can discuss it later in the patient seminar. There are some studies that show some improvement using steroids, but the question is, does it really alter the disease course? Will taking steroids make you resolve quicker? And we really don't know that answer. And anyone who's taken steroids knows that there's risks. Diabetes, hypertension, joint necrosis, mood alterations. We get this all the time from our families and friends that come with our patients. Get my wife or husband off these steroids. He or she is driving me crazy, all right? Weight gain. Even death has been reported giving steroids. Here at our eye center, at the UCSD Thyroid Eye Center, we use steroids very judiciously. We give them around the eyelid, in a temporary fashion if needed, and we will give it for patients with optic neuropathy as a temporizing measure before we take our patients to an operation. Medication supplements, there's a whole list of this. You go on the internet, I just did a search, just a few days ago, page after page comes up of different supplements, all right? I can tell you that nothing has definitively been shown yet, but we have patients who come in and tell us that they've taken certain medications that have really made a difference for them. For us as scientists and clinicians, we like to wait for really nice controlled trials with placebo arms so we can really determine, should we recommend this compound to you or this treatment to you. What has been shown is the use of selenium. Now, does anyone take selenium in here? Okay. Most of you have read about it, okay? Selenium is an antioxidant. It's given at a dosage of 100 micrograms twice daily, and it is shown to have an improvement in a large study in Europe. However, the caveat is that this group of patients that was treated with selenium was treated in an area that was deficient in selenium, okay? So we still don't quite know, does it work well or not, but it's pretty well tolerated, and if it's well tolerated, I would say that, it would be safe to take it unless you develop some of the side effects. So after the exam, when patients come in, they want the treatment, they're demanding for us to fix them right now, we tell them you gotta wait. Well, is there anything you can do now, all right? Well, the one thing that we know that will really affect the disease and cause for the worst symptoms in our patients is smoking, okay? In addition to the cardiovascular, the lung problems, the skin changes and so forth, we know that our smokers have the worst disease. So stop smoking, please. And I know it's not easy, all right? Your heart rate's high, your mood has changed, and smoking tends to cut down on some of these symptoms for our patients. But we know that if you smoke, your disease will be worse. And some of the worst cases of optic neuropathy we see are in our smokers, okay? And common sense things, healthy diet, exercise, follow up with your endocrinologist and your ophthalmologist on a regular time point. So with this, I want to let you know that there is hope, okay? You're not on your own here. There is a light at the end of the tunnel, okay? So we'll save questions for, I think, the question session, and I'll have Dr. Cacao introduce the next speaker. Thank you very much.
Thank you, Dr. Korn. The next speaker is Dr. Granite, and we're very honored to have Dr. Granite here. Many of you may recognize him from his award-winning TV show. And Dr. Granite has hosted Health Matters for probably close to 20 years now, and he's had over 1 million viewers. He's a very engaging speaker. And Dr. Granite and I were very fortunate to start our Thyroid Eye Center almost 20 years ago, and we've had the great pleasure of caring and honor of caring for many of you as patients. And Dr. Granite is going to talk about the double vision that is seen in patients with thyroid eye disease. Dr. Granite?
As Dr. Cacao said, we started at the same time, and I hate to ever correct him, but there's been 10 million downloads of the show, not 1 million. This is really a pleasure to be able to have a chance to spend some time with you guys and chat. We don't get as much time as we'd like in the clinic, no matter how far behind schedule we run as we're sitting and talking to everybody. But the value of sitting here and chatting together is really, I think, very important. So the first thing I wanted to do was talk about the dress that was on the internet yesterday. I think by now everybody knows that the dress is actually blue, if you haven't heard that already. And in case you care, it's all in the context of the bright light and what you think is actually going on, if that's a white dress with blue light bouncing off of it, et cetera. So let's talk about Graves' disease. Graves' disease is an old term, right? It goes back over 150 years or so or more. And so we always want to honor the past and remember what's gone on before. But an authority no less than Queen Elizabeth said, bow to the past, but don't be bound by it. And so we're constantly trying to do better. What I wanted to do today was give you actually the same detailed information that I give when I lecture and speak and teach ophthalmologists. I think that each of you becomes an individual expert as you go along, and we want to make sure that you have the detailed information that you actually want. So this is the slides I'm going to show you today come right from a talk I gave 2 weeks ago in Hong Kong, updating doctors there about the same thing. So I want you to hear the same level of detail that they might hear, so you know what's going on. This already is covered by Dr. Korn fabulously. And what he talked about was how the muscles get bigger as part of the immune response. Well, what happens is all these cells start to go places they shouldn't be, like the muscles, and they start to swell into the muscles, fat, and the connective tissue. And that not only swells the muscles up, because I'm a muscle specialist, it also causes the muscles to degenerate and become fibrotic. So instead of being elastic, like a rubber band, they turn into rope. And that changes their function. And now you get, and I'm sorry, but some of the pictures are going to be graphic, so if anybody doesn't like that, I apologize, but it's the only way for me to give you the kind of detail that you want to know. These muscles are gigantic, or as my son would say, ginormous, in their size, and they don't give the chance for the eye to move. They're not rubber bands anymore. They don't give the flexibility that you would like. And so you end up with eyes that don't move up and down or around in the way that they're supposed to. That leaves patients really frustrated. And Dr. Korn talked about this. You end up disfigured, you don't look like yourself, you end up with double vision or diplopic, and you end up with heartburn or dyspeptic because you're not happy about it. And we don't blame you. You heard about the 5-step approach, which is the most beneficial thing that we do and the most frustrating thing that we do, because we make you wait as we step through each one of these problems and in a very, very methodical way, because we want to make sure things go well. So if you look at it, here's a patient, and Dr. Cacao and I would say patient number 1, because it was this patient that actually led us to decide that we needed to form a thyroid center. So when we saw him, we felt a little bit like this. And we had, what are we going to do? And we stepped him through each one of the steps, and we ended up getting his eyes from there to here, where he could use his eyes well together again. We've learned so much in the Thyroid Center, and that was one of the things that Dr. Korn mentioned. All the different research that we have done has come so much from what you have allowed us to do and what you have taught us by the words that you say to us, the sharing that you have, and by allowing us to participate in your care. over and over and over. And many of you come to our center and you have lots of young doctors that are around. Those young doctors come in the back room and they ask us questions and we go, let's study that, because we may not know the answer. And so that leads and spurs us to do more and more and try and understand this better, bowing to the past, but trying to do better and move forward as we go along. So what I want to tell you a little bit about is what we've learned when it comes to eye muscles. And the number one thing I'm going to tell you that we learned at all, Dr. Korn has touched on, and probably all of us will touch on, and that is the impact of this disease on you as a person. And the level of depression and anxiety that comes along with this disease is really almost hard to explain. Dr. Cacao and I bet $20 on this one. I bet him that function was more important than change in appearance. I lost. Change in appearance was worse than change in function. One of my patients explained it to me this way: Dr. Granite, I can get rid of double vision. Watch. Can't get rid of how I look. When you hear people talk about how their grandchildren are afraid of them or they won't go outside, the impact of not being yourself anymore is just even hard to put into words. It is real. And if any of the spouses are here, you should understand what your spouse is going through. It is really hard to explain if you haven't lived through it. But we have heard person after person talk about it. We have had days where we'll see 20 patients and 18 are sobbing in our office. This is real. And so that's one of the things that's very important to recognize, that not only does thyroid, a change in your hormones, affect you, but now you're not yourself, you don't look like yourself, and you can't function like yourself. So that's one of the things we learned. Now, from an ocular motility standpoint, up to half of patients will develop some sort of change in the way their eyes move. It's a big deal. Why? Because those eyes, the muscles are big. And there's a specific order that typically the muscles go in. The bottom muscle, or the inferior muscle on the bottom of the eye here, is the first one to go. The medial, or the one closest to the nose, is the second. That means typically your eye goes down and it goes in. So you get that type of double vision. If both of them happen, sometimes you get not only a horizontal change, but a vertical change. You can get double vision this way, where it's diagonal. You can get double vision where the images cross. You get double vision where the images are up and down. Dr. Korn showed you what those pictures look like. It's terrible. All the muscles, however, can be involved, and there's some ethnic differences in how those muscles get involved and how they change. And so when we approach this disease, depending upon how many muscles there are involved, it changes what we do. That's why we do those examinations so carefully, to make sure we understand the pattern of the eye movements that you have. That's why we need a CAT scan beforehand, because we want to see how big those muscles are and which muscles are involved. We now have a better understanding from work that was done at UC Irvine about which of the muscles are involved and what order they're involved. It has to do with the constitution of each of the muscles, which is somewhat different between the inferior, the medial, and the superior. We know there's some other treatments that we can do while we're waiting to see if you stabilize. That includes a patch, which we hate, and it also includes prisms, which isn't so great either. When you have this problem, your eye gets stuck and it won't move normally. That means as you move around, the double vision changes from left to right, from down to up. A prism, which shifts an object, doesn't change as you look around. So you're constantly changing and the prism doesn't. And that's why it's often unsatisfactory to most people. For small deviations, early in the disease, often prisms can be helpful. What else have we learned? We've learned how to use Botox, as Dr. Korn talked about. Botox has been used in eye muscles as its origination in the treatment in any medical problem back in the 1970s. It's where it first started. And so we tried to figure out, does it have a role in thyroid disease? And we presented this data at national meetings, and we actually had an opportunity to show this on national television as well, where I was asked to demonstrate whether or not Botox can be used for eye muscles, which was just sort of funny because it is the primary use for it. And if anybody is a little bit squeamish, in a few seconds you'll see me doing an injection of the Botox into an eye muscle. This is Travis Stork talking to me. By the way, they misspelled ophthalmologist at one point when you look up here. So, and this is by the internet, they did this, and they showed me a video. It's just putting a needle, some of you have had this, into the muscle right here in the office with some topical anesthetic, like a dentist might put on your gums. We just slide it right in. There's a wire that tells us by sound when we're in the muscle, we can hear it. We do a small injection of Botox, and we get out. It relaxes the muscle. It works very well in some people. It works phenomenally well in some people. And the smaller your deviation, the better it is. And there's some people in this audience who have had Botox injections, and that's all they ever had to get rid of their double vision. How great is that? It doesn't work in everybody, but it does help. In fact, in some people, although it doesn't fix the problem, it gives you some relief for a short period of time. And then it may actually make your deviation, the amount your eyes are offline, smaller, which is a lot easier for me to fix. The smaller the deviation, the easier it is to fix. And we demonstrated all that, and we presented that at meetings. So we do know that the intervention when the disease is smaller, or the deviation is smaller early in the disease, is better. And that Botox may reduce the final amount I have to operate. That's great. Well, for every reaction, there's an equal and opposite action. And what we demonstrated also was, and you report the good news and the bad news, is that in a very small percent of people, that shift in the eye location can take those very large muscles and have them push on the optic nerve, forcing us to do something earlier for an optic nerve problem. We're aware of that. We know who that's more likely in, and we can take that into account as we go forward. Well, the other thing that happened is the fact that Dr. Korn, Dr. Mcgowan, and I were in the room together allowed us to have this conversation that goes on. There's nothing like presenting your work in front of your colleagues. There's nothing like having smart people to bounce off of. And what we said was, well, what if we use the Botox at the same time as Dr. Mcgowan and Dr. Korn do a decompression? And that only came up because we were in the room together. And so we said, okay, let's see what happens. They have direct visualization of the muscles. So at the same time as they're doing a decompression, they can do an injection of the Botox to help move the eye and loosen it up at the same time as they do it, which turns out to have worked quite well. And they presented that data at the National Oculoplastics meetings and showed the value of it quite a long time ago now. And we're able to use that modality, Botox, at the same time as decompression to help align the eyes, and it makes a big difference. Again, something that only happens because we're in the room together. This woman had decompression and Botox at the same time. This eye is lower or pulled down because that lower muscle got big. That's all she had. Never needed muscle surgery. Avoided it because the injection was done at the same time. The other thing we found out is that the big muscles push on the eyeball. And when they push on the eyeball, they raise your pressure. It makes you look like you have glaucoma. And there are some patients that we have taken care of that have been told they need glaucoma surgery. And what we found out is that when we do the Botox injection, relax those muscles, the pressure goes down. We also demonstrated the same thing happens when we operate on the muscles. So there are people we have prevented from having glaucoma surgery by operating on their eye muscles. So glaucoma you can be fooled when your eye muscles are enlarged. It's an important thing that we found out, again, because ophthalmologists are in the room together discussing this with patients. What if? Could it be? Is there another alternative? That putting the heads together, that multiple heads are better than one, really has value. Then finally we get into surgery, which we try and wait until we are at the end game if we have to. There are some people that have promulgated, and this is David Coates from Texas. He said, what if we go early? Well, if you go early, at least half the patients need a second surgery. That's why we try not to go early. Imagine I get your eye straight, but the disease is progressing, and then you shift again. How frustrating that is to have it taken away from you just as you get started. We're trying to aim, originally it was just looking straight ahead. We try and do much better than that. We want you straight ahead. We want you to be able to look down to function. We want you to be able to look left and right. We call that the window of vision. It turns out that no one talks by turning their head dramatically. I would never face this audience and go, hey everybody, how are you? And try and look over to the side. I would turn my head this way. We move our eyes about 10 or 15 degrees and then we move our head. So if I can give you 10 or 15 degrees of movement, side to side, down, and maybe only 5 degrees up, because we don't look up that often, unless you're a pool player, then you might be looking up more often, but like this. But so we take that into account, what your job is, what your needs are, but we're trying to give you that range of motion so that on an average day, doing average things, you can function. On a day where you have to do something else, change a light bulb when you're looking up, back up a car and look all the way over your shoulder, perhaps, maybe you will encounter double vision. But for an average day, we want to give you as much as possible. Turns out there are other things that we've learned. It turns out that when you do eye muscle surgery, because those muscles are so big and large, they can distort the eye, and you can need a change in your glasses. So we try and not give you new glasses until then. When we operate, we adjust and move the eyeball around and the muscles around inside the operating room. And that's been published by other doctors, including us, about how we do that in the operating room to try and balance the forces. Many of you know who've had surgery with us that we do adjustable sutures. At the end of the surgery, you don't tie a permanent knot, we put a slip knot there. If that doesn't hold, if your eye is not in the position that we want, rather, then we can slide that muscle just a little bit in the office. And we've pioneered doing that days later. We have special equipment, grooved hooks that we don't need for other surgery, equipment that we have designed to grab the tissue and hold the tissue specifically for thyroid and adults undergoing muscle surgery, which is very different than children undergoing muscle surgery. And these are all the equipment that we designed right here at Shiley. We have music in the operating room, very important for every surgeon. Along with my partner, Dr. Shira Robbins, we developed this delayed adjustable technique. We wait a week and we decide whether or not your eyes are aligned. We give you a chance to get back to yourself, to see if your brain can use the eyes together before we make a decision. Whereas many people across the United States, most people across the United States, try and adjust within the first day. The advantages of delaying are all these that you see in front of you. You can cooperate better. Your brain gets a chance to use your eyes together. You have a real huge positive. And what we do basically is, after we take those stitches and we have them hanging out of your eye, we just tuck them under the covering of the eye, and that white part is the covering of the eye. We tuck the stitches underneath, close it up, let you go home, and use your eyes normally. If I need to, I can get to those stitches and slide them around if I have to. It's a big advantage for us. All right, and there's all sorts of other things that we do with the muscles, small deviations. This is Southern California. Nobody wants to wear glasses if they don't have to. They don't want to wear prisms. We've developed techniques that allow us to make very small, little tiny cuts in the muscle that align the eyes if they're not perfect. We've looked at all the patterns because of the kindness of you all allowing us to study you. We can look at the patterns of the deviation. We have better answers now than we used to. We're using biomechanical studies right now. We're using computers to analyze the muscle forces, to look at the stiffness and the rotational capability of the muscle, using computer programs to try and predict where the eyes may be. We can take the clinical information that we have, put it into a computer program, analyze it, and figure it out. With Dr. Korn and Dr. Kikawa, we figured out that when we cut the eye muscles, the eyes tend to bulge forward. So we take that now into account. These tethers holding the eye back change how bulging forward you are. So Dr. Kikawa is going to talk to you about decompression. We'll take that into account when we're doing surgery. We know that now these eyes, which are pushed forward past the orbital bones, after the decompression are pushed back, the eyes are out like this. They can't move around. So trying to fix an eye that won't move is very hard. But when you bring them back, now they have room to move. It turns out that the surgery that Dr. Korn and Dr. Kikawa do give us much more room for strabismus. And recently, one of Dr. Kikawa's fellows, along with our whole group, looked at that data and showed the pattern of the eye muscle deviation was improved and easier for me to fix after they do their decompression. It really matters to have a great decompression before I go ahead. I didn't know that. I just took it for granted because I've been working with two of the world's experts for all these years. I didn't realize what was happening, why our results were better. Now we know our results are better. That great decompression makes a huge difference. So all these techniques matter. Sometimes we lay it up and leave ourselves an easy putt. That way, with all this careful planning, all this effort, we can end up avoiding problems which none of us would like to face if you plan carefully. We know that the muscles can change the eyelid. These eyelids are popped way open because those lower muscles were stopping the eyes from straightening out. Once I did the eye muscle surgery, the eyelids came down. They didn't need to be operated on. There are challenges that we face, why one eye is involved and not the other. But we've done a pretty good job in trying to fix that with a woman like this who goes from one eye down to her eye is now having difficulty moving. Decompression is done. You can see much better improvement. I do eye muscle surgery, and we're able to get her eyes pretty straight. Then we do lid surgery eventually, and she looks pretty darn good. And she's pretty happy with herself at the end. We are hoping that one day we won't need to operate on everybody. There's a lot of work being done now on immune therapy. It's pretty exciting. Rituximab does not look so good right now, and this is a letter that we wrote about that. But there's other treatments that look very exciting that are coming in the literature that some of you heard of us talk about that we're really excited about that may herald a change in the way we treat. There's new immunomodulation that we're looking for, anti-TNF drugs and other things. We are not beholden to the past. We are trying to keep going forward. There's ways to maybe change the muscles that we're looking at and trying to loosen them up. So we think that we are going to be able to change this disease and not have to go from here to here, but stop it from ever getting there. And that is our eventual hope. Thank you for all of that you've allowed us to share with you and for what you've shared back with us. And there'll be time for questions in just a minute. I ran a couple of minutes over, but I think it was worth it. Thanks very much.
Thank you, Dr. Granite. The format for today is going to be a series of physician talks, and we're about halfway through that. And then we're going to have a physician panel that will moderate with questions. And then following that, we'll have a patient panel. But to continue on the physician talks, I'm going to talk about orbital decompression. And as some of you may have gathered, orbital decompression at one time was thought to be a very dangerous operation. And we've seen many patients come through our clinic that have told us, this doctor told me never have it done. It's too dangerous. But the fact of the matter is, when we have patients that have gone through many years of inflammation with the eyes bulging and have had medical therapy, there really is no other way that we can get patients back to their pre-disease state. And that really is the gold standard. How do we take someone with a disease, a disfigurement, and take them back to how they were before they ever had the problem? And that's really our goal with surgery. So modern decompression has evolved over the last 100 years. It was actually described many, many years ago. And it actually, nowadays, is thought to be fairly effective in reducing the bulging, the chronic pain that patients get, the pressure feeling. And if you look at this, we've actually modified it so that it can be done as an outpatient. I mean, before patients were admitted to the hospital, they were required to be an inpatient. We still do that on occasion when both eyes are done, but if we do one eye at a time, we can do it as an outpatient. And it should be performed in the stable phase, the slide that Dr. Korn showed. We don't want to operate on patients while they're still changing. We may modify and do it earlier if we have to in patients that are losing vision, but for most of the time this is done after the disease has run its course. What are the indications? Well, the main indication could be someone that's losing vision. As Dr. Korn showed, if the colors start to get washed out, they don't respond to medical therapy, we will consider performing this operation for that. Exposure keratopathy, when the eyes are pushed out so far that the eye dries out, the cornea starts to become ulcerated because it's dry. Disfigurement may be the main indication nowadays. Patients, you heard Dr. Granite share that patients are so upset with the way that they look, they can't continue their normal social interactions, they withdraw. Many patients will come and they would like to look as much as they can like they did before. And then in preparation for strabismus surgery. If the eye is pushed out so far, we know when Dr. Granite does muscle surgery that the eye may bulge out even more. We have to prepare the orbit to give it more freedom so the muscles can move. It's important to look at patients progress, and this is one of our patients that was actually on our panel last year. And we asked patients to bring old photographs in when they come see us, and you can see the changes are very, very slow. This is Jerry, as she was before the disease state, and just over a slow period of time, over years, she gradually changed to where her eyes were prominent. One eye was looking down, her eyelids were retracted. And our hope is that with surgery, we can restore patients as best as we can to how they were before. So if you look at Jerry before the disease started, at the peak of the disease, and then when we're finished with her surgical rehabilitation, you can see she looks very close to how she looked. She doesn't look exactly how she looked before. In fact, she actually likes the way she looks now better because she has a little bit more lid showing. But that's our goal. How do we try and get patients back to how they were before? That should be the gold standard of any operation. And we're close. We're not 100% perfect, but you can see that there is a dramatic improvement. Here's Miss Senior San Diego for 2014. This is another one of our panelists from last year. You can see Joyce here. This is her before. When the pre-disease state had not come along yet. Here she is at the peak of her disease. And here she is after undergoing surgical rehabilitation. And she felt so good about herself now, she entered the Miss San Diego contest last year, and she won. Here's another patient, one of our panelists last year, again, looking at all three pictures. And really, when we look at photos, and we talk about this on a national level, We often see, the photo of the patient here and the side, the resulting photo. But for us to raise our game, as Dr. Granite said, to be the best we can, we really have to look at the pre-disease state and see how close we are achieving that. One of our panelists today that you're going to meet, she'll share her experience. So point number 2, decompression needs to be tailored. It's not an all or none operation. There are walls, as Dr. Korn pointed out. There are different areas of the orbit that we can address with surgery. We actually tailor that to address how much we want to get the eye in. This is just a table that we use as a guideline. We teach our residents and fellows as to how much to do. Just to show you briefly where the surgery is done, I think you probably have gathered from the other talks, we're actually targeting the bony structures around the orbit. This is the orbital soft tissues are encased in bone, and as the tissues swell, they have no place to go but come out. So we actually use very fine instruments. We sculpt the bone, we expand the tissue into the sinus cavity, which is this darkened area, to give the orbit more space. These are some examples of some patients that have had fat decompression. This is the more mild type of disease. You might look at this patient and say, well, it doesn't look so bad, but she still doesn't look like she used to. She has this pressure behind her eyes. This is just taking a little bit of the fat and bringing her eyelid down. The second area that we would address surgically is what's called the lateral wall. If you look at this bony skeleton, this is the area shaded in green. This is the nose, so this is actually the right eye, the right orbit we're looking at. This here, shaded in green, is the lateral wall. It's probably considered one of the more safer walls from a surgical perspective that we can operate on. This is a patient before and after a one-wall decompression. The next wall we would consider decompressing is what's called the medial wall. This is shaded in blue. If you look at this, we're addressing the so-called balanced decompression, where we're taking tissue away from the side on the outer part and the inner part of the eye. And the thought is that the eye comes back kind of in a balanced fashion. So it somewhat balances the risk of getting double vision, which is always a risk. Another patient here underwent a 3-wall decompression, where the 3rd wall we add on is the area shaded in red. This is the orbital floor. This gives an additional space for the eye to come back. And then in our hands, a so-called maximal decompression, where we actually do those 3 walls in addition to the area shaded in yellow here, allows us to get the eye back as much as 10 millimeters. There are some well-recognized side effects. Double vision has been reported in varying percentages between series. If you use Dr. Granite's philosophy, the double vision that's created may not actually be such a bad thing, because it gives the eye muscles more chance to move. It returns them more to their pre-disease state. We don't necessarily consider double vision a devastating complication, because we know it can affect patients, but we know Dr. Granite usually is able to get the eye into, again, a very area of single vision. So I know it can be very troublesome. And if you look at the side effects of having it after decompression, most of the time we're able to alleviate that with additional surgery. There may be some temporary numbness around the eye. There are some nerves that run very close to the orbital bones. We preserve the nerves. Sometimes they do get a little bruised during the surgery. Most of the time the numbness comes back. We're performing surgery in the sinus area. Sometimes it's not uncommon to see a sinus infection afterwards. That typically is something that's very rare, but it can be treated. And then vision problems are very rare. If you read about this on the internet or look at the medical literature, there have been reported cases, very rarely, of vision loss. In good hands, that's a very, very rare complication. Some of the other things that we can do from a surgical perspective, the eyelids may still be pulled up. This is eyelid surgery to bring the eyelids down. Another patient that had upper lid blepharoplasty, where we take some of the fatty tissue and eyelid skin that recurs over many, many years of having it stretched out. We can address that surgically. And then the lower eyelids may also pull down. This is a patient who had lower lid retraction before and after repair. So in summary, in the right hands of an experienced surgeon, modern decompression is safe, but it must be tailored and address each patient individually. At this time, we're going to move to our next speaker. It gives me great pleasure to introduce Dr. Karen Mcgowan. Dr. Mcgowan is an endocrinologist. She's here on the faculty at UCSD. She was on faculty at Harvard, and Harvard's loss is UCSD's gain. And she's going to be speaking on the endocrinologist's view of Graves' disease.
Okay, good morning. I'm going to start with a case. This is a 40-year-old woman with a 6-week history of quite a lot of symptoms. So she's got tiredness, she's got a racing heart, she's not able to sleep, she feels that her muscles are very weak, she's not able to do her hair, she's not able to get up out of a low chair, she's very warm, she's lost weight. That's a striking symptom. And her periods were a little bit light over the last couple of months, and she has itchy skin. That's an underappreciated symptom of hyperthyroidism. I don't know if anybody else has experienced itchy skin, but it's poorly appreciated. Don't send the patient to the dermatologist. Consider the thyroid. So when I examined her, she had quite a fine tremor to the outstretched hands. And in some patients, you can't see the tremor if you're standing the other side of the room. You actually have to go up and put your hands over the patient's hands, and you can feel the tremor. You may not be able to see it, but you will feel it. Her heart rate was up, her skin was warm, her eyes were normal. And her thyroid was the upper limit of normal size, and I didn't think that she had any nodules. And she had lab work that was consistent with thyrotoxicosis. So thyrotoxicosis is a word that means overactive thyroid. It doesn't tell you anything about the cause of the overactive thyroid, whereas the word hyperthyroidism means that you have an overactive thyroid. And we'll go into that a little bit more. So in her case, her TSH was totally suppressed. Are you all familiar with the TSH? Yes. Her free T4, her thyroid hormones, T4 and T3, were both quite elevated. So sometimes when patients look at their lab tests, they see that the TSH is very low, and they think that that means that their thyroid is low. But does everybody understand why the TSH is low in hyperthyroidism? Does anybody like me to explain this? No? I'll explain. Okay. So this is the thyroid, and this is the pituitary gland. And they act together. And the thyroid makes thyroid hormone, T4 and T3, based on the amount of TSH that the pituitary gland sends out. So the pituitary sends out TSH into the circulation, recognizing the amount, the thyroid decides how much thyroid hormone to make. And then the pituitary can see how much thyroid hormone is in the body. And so somehow, if you have a lot of extra thyroid hormone, maybe you took it out of a bottle, or maybe your antibodies cause your thyroid to release more, but for whatever reason, if the thyroid hormone level rises even a smidge, the pituitary, the master gland, says, oh, that's too much. I better make less TSH. And it thinks it's going to cause your thyroid to make less thyroxine. So the hallmark of a messed up thyroid gland is an abnormal TSH. So early in an underactive thyroid, the first thing you'll see is a slight rise in TSH. Early in an overactive thyroid, you'll see a suppression of TSH. So that's why the TSH is low, but it means an overactive thyroid. So differential diagnosis. So we kind of know maybe she's got Graves' disease because that's why we're here. But is there a possibility she's got something else? Was anybody else diagnosed as having anything else before they actually got diagnosed with Graves' disease? Flu. Speak? Flu. Okay. Yeah, but if your doctor did the TSH, not flu. But potentially related to flu. Have you heard of silent thyroiditis? It's thyroid inflammation. It can give the same appearance on the thyroid test, and sometimes it's a little tricky to tell the difference. The other possibility are hot nodules. Theoretically, a good endocrinologist can feel the nodules and would know that you don't have hot nodules, but those are pretty much the differentials. So it's not that difficult to diagnose Graves' disease. How do you tell the difference? Well, you tell the difference from the history, the duration. If it's silent thyroiditis, that's a short-lived illness. You start with symptoms of overactive thyroid, and then you become underactive. Nodules in Graves' disease are often going on a little bit longer. Patients with thyroiditis and patients with nodules do not have any eye manifestations at all, with one exception, which is the eyelid can be a little bit retracted just from the effect of having too much thyroxine. But you do not get proptosis. You do not get any of the other eye symptoms if you have any cause of hyperthyroidism other than Graves' disease. I think that's right, but these guys can butt in if I'm wrong. Lab work, you can tell the difference because you can measure antibodies, and they will be positive and elevated in Graves' disease and shouldn't be in the others. And then, did most people have a radioactive iodine test to make the diagnosis? Yeah. You don't have to do this. It's expensive, but if you're not sure what the diagnosis is, it is the definitive test. So Graves' disease, we've been through a little bit. Nobody really knows the exact cause. There's clearly a genetic predisposition, plus there are environmental factors. And we've talked before about the antibodies that can fool the thyroid gland into thinking that there's excessive TSH. So the antibodies can act through the TSH receptor on the thyroid gland. And I'm proud to announce that He was not English. A lot of the time when you go to talks, he will be labeled as a Brit, but he was actually an Irishman. He described it in 1835. Back to our patient. So she's clinically hyperthyroid. She's biochemically hyperthyroid. And she had a radioactive iodine uptake and scan that showed 2 big, juicy, hot lobes. So this is a gamma camera taking a picture of the thyroid after the patient has ingested radioactive iodine. And the reason this is diagnostic is if the patient had a hot nodule, then all the radioactivity is concentrated here, and you can see that the rest of the thyroid doesn't take up radioactive iodines. This is not Graves' disease. This is thyroiditis. Thyroiditis is thyroid inflammation. Flu, maybe. Some sort of virus or shift that causes leakage and destruction of the thyroid gland, so it doesn't take up any radioactive iodine. And this is Graves'. So, does one treat Graves' disease? Yeah, mostly, but in a young person who's not terribly symptomatic, sometimes I'll watch and wait. But in general, most of the patients that come see me come to get treatment. So, did most people in the audience receive beta blockers when they were initially diagnosed? It's a common treatment. What it is it lowers the excessive manifestations of thyroid hormone, so it lowers the heart rate, slows everything down, it makes people feel a lot better, but it doesn't do anything specifically for the thyroid gland. On the other hand, there are 3 specific therapies for the thyroid: surgery, radioactive iodine ablation, and tablets. And unlike what we've heard before, there's little new in medical therapy of Graves' disease, I'm sorry to report, but the tablets do work fairly well. So who's had surgical thyroidectomy? Not many. Who's had radioiodine ablation? Who's had medications? So it's split between radioiodine and medications. Okay. So the drug of choice is methimazole. But when I was training, PTU was probably more common. It's the only other alternative, propylthiouracil. It's out of favor because of reports from the pediatric literature of increased liver dysfunction. My patients used to complain of a nasty taste in the mouth. The other thing that PTU has is a short half-life, so PTU is dosed a couple of times a day, whereas methimazole has much longer half-life and can be given 1 time per day. And methimazole has very few side effects, nausea and rash. Anybody taking PTU? Methimazole? Yeah. Okay, so my patient, I gave her a beta blocker, anticipating 4 weeks of therapy until she felt better, and I gave her metoprolol twice a day. And I gave her methimazole. I tend to use 5 milligram tablets because I like to taper, and I like to taper by doses of 2.5 milligrams. And you cannot cut a 10 milligram tablet into 2.5 milligrams. So no matter what my starting dose is, I generally use 5 milligram pills. And I started her on 10 milligrams, anticipating she'd be on therapy for at least 6 months. So if I give her some therapy and her tests become normal within 6 weeks and I stop her medications, she will immediately relapse more than likely. So in general, a minimum of 6 months is necessary to achieve some sort of immunological remission. The thought is that the methimazole can have an immunological effect on the thyroid, not on the eye, just the thyroid. Okay, question for the audience. What should you do if you get fever, rash, or mouth ulcers? This is really important. We can take a poll. Okay, the options are: go to the urgent care, call your primary doctor, wait for it to go away, worry that your Graves got worse if you have a fever and increase the methimazole, or call me. Okay, who votes for the urgent care or the PCP? Nobody? That's not my experience. Who waits for it to go away? Bah. Who takes more Tapazole? I have seen this. Who calls the endocrinologist? And why? Okay, be more specific. Sometimes. Why do you call the endocrinologist, any endocrinologist? Why do you not go to urgent care? This is so important. If you go to urgent care, they'll do a throat swab. It'll be negative and they'll send you home, or positive, they'll give you some antibiotics. This is a very rare side effect. It's called neutropenia. It means a very low, particular class of white blood cells, polymorph cells. It's really rare, 3 patients in 1,000. But I've seen it a bunch of times. And one of the patients in whom I saw it thought, oh, I have a fever, my thyroid's getting worse. Oops, I better double my methimazole. It can be fatal because you cannot fight infections. You become almost like a cancer patient. So I always quiz my patients every time I see them. If you have a sore throat, what do? You don't go to urgent care. You call the endocrinologist. You have to get a specific white blood cell count. So if you go to urgent care, they may do a white cell count, but they'll do a total white cell count. So anybody taking methimazole needs to know this. Okay. All right, so which treatment do I choose for my patients? Radioiodine, methimazole, or surgery? I present all 3 options to the patients, and we decide together what's the most appropriate treatment. Where I did my residency, it was at a big referral center, and patients would fly in from the Middle East. Everybody got radioiodine ablation and got sent back home, sometimes on planes to various places. It's a very personal decision. The only time I make a comment is that I don't like to use radioiodine ablation if the patient has evidence of Graves' eye disease, because there is a suggestion in the literature that sometimes the Graves' eye disease gets a little bit worse after radioiodine. But that is controversial. In young people, I do try to tend to use methimazole, rationalizing that if I give radioiodine or surgery, they'll be hypothyroid permanently, and that may limit what they want to do in terms of traveling, stuff like that. So I tend to use a lot of methimazole. Back to my patient. She did great. I lowered her dose by 2.5 milligrams every 2 months or so, and she remained euthyroid on half of a tablet, came off the medicine, never developed any eye symptoms. So in summary, nothing fancy. Graves' disease is common, particularly in young women. Wide variety of symptoms, runs in families, and we have 3 very effective therapies, which is perhaps why we don't have anything new. And my only caveat about the eyes is radioactive iodine. So thank you, but no questions, I guess.
We'll hold those for the Thank you, Dr. McGowan. The next speaker is Dr. Michael Bovee, and we're very pleased to have Dr. Bovee here. He's the director of endocrine surgery here at UCSD. Probably has one of the busier thyroid surgery practices in the country. And he's going to share with us his experience of thyroidectomy, go through the indications, the surgical procedures, and then maybe share some interesting perspectives on newer information about surgical thyroidectomy. Dr. Bovee?
Thanks, Don. And it's a real pleasure and honor to be here talking to you today about thyroid surgery for Graves' disease. It doesn't sound like too many people in the audience have had thyroidectomy, but I'll go ahead and tell you a little bit about that. That's my cat. Okay, here we go. So the thyroid, as you all know, is a gland that sits in your neck, and this is just a picture of the thyroid, a normal thyroid that sits around the windpipe, the trachea. And when you get somebody like this patient, the thyroid is very enlarged, and she had Graves' disease. You can see, just looking at her neck, how large that gland was. So hyperthyroidism, or an overactive thyroid gland, is caused by various things, but Graves' disease is the most common cause. And that typically occurs in young women. There's actually an 8-to-1 ratio of women to men for some reason. We don't know why, although I have seen plenty of men in my clinic with Graves' disease as well. Other causes of hyperthyroidism are toxic adenoma, which means a small tumor that's secreting too much thyroid hormone that can be treated with surgery, or a toxic multinodular goiter, Plummer's disease, again, can be overactive, and then taking too much thyroid hormone can cause hyperthyroidism, or rare things like hyperactive tissue in the ovarian teratoma or desmoid. And we've heard about some of the symptoms and signs of hyperthyroidism: nervousness, restlessness, emotional lability, fast speech, fine tremor, and then you can get this tachycardia or palpitations, arrhythmias, even dyspnea, and then all the other symptoms that we've heard about today with lid lag, proptosis, exophthalmos, ophthalmopathy, also other things like increased sweating, fatigue, weakness, hair loss, leg swelling, and myxedema. This is a lady who underwent a thyroidectomy a few years back, and you can see the typical proptosis that she has with her eyes. And we heard about from Dr. McGowan the different treatment options, the medical treatment, either PTU or methimazole, radioiodine ablation, or surgical removal of the thyroid gland as definitive treatment. There was a recent article that just came out a few months ago in the ophthalmologic literature showing that a combination of statins, which actually decrease inflammation, and thyroidectomy might reduce the risk of developing eye problems in patients with Graves' disease. And there was a nice editorial in Clinical Thyroidology about it. It wasn't a perfect study, but it was sort of a population-based study where they looked and they noted that the patients who did get surgery had a lower risk of developing eye problems. So if that's what you've decided to have, then you might be referred to a surgeon, a thyroid surgeon. This is just a little video of a patient that had a large goiter, and she emailed this to me and said, would you be my surgeon? And I said, sure, come on over. So you can see how large her goiter is there. She was actually having some problems breathing and swallowing with that. So one thing I have to spend a lot of time with the patients, and when I see them in clinic, is sure, I can remove it, but there are some known complications of surgery for thyroid conditions, and these are listed here, and we'll go through them. Hypothyroidism, hoarseness, hypocalcemia, bleeding, problem swallowing, and infection, very rare. One of my surgical heroes is Theodore Coker. He was a Swiss surgeon who performed over 2,000 thyroidectomies and won the Nobel Prize for his contributions to thyroid surgery in 1909. And he was very famous, but he actually thought he was a failure. This is a quotation for him. He said, "In technical terms, we have certainly learned to master the operation for goiter. We can deal with bleeding and prevent loss of speech. Billroth tetany is so unusual that it has not made us change our methods, but something else has also happened. Removal of the thyroid gland has deprived my patients of what gives them human value. I have doomed people with goiter, otherwise healthy, to a vegetative existence. Many of them I have turned into cretins, save for a life not worth living." What he didn't understand was that when you take the thyroid out, there's no thyroid hormone, and you have to take thyroid hormone or else you become very hypothyroid. So we've come a long way since then, and of course now we have L-thyroxine or levothyroxine, which we give to all patients who've undergone thyroidectomy, a total thyroidectomy, and basically we calculate the dose based on the weight of the patient. And we would check a TSH level about 6 weeks after starting. If we are operating for a thyroid cancer, which I do a lot of, then we'll start patients on a different preparation, T3 instead of T4, in preparation for radioactive iodine. So, of course, that's one of the things. If you get your thyroid out, you won't have to take the methimazole anymore, but you will have to be on a thyroid hormone once a day for the rest of your life. The other critical thing about thyroid surgery is there's some very important nerves that control your vocal cords and make them go back and forth. And these nerves are illustrated in this diagram. Here are the part of the vagus nerve, branches of the vagus nerve called the recurrent laryngeal nerve. And they innervate all the muscles of the vocal cords. So there's a chance those nerves could be injured during the surgery, and it's anywhere from 0 to 5%. If they are injured, it could result in hoarseness, voice fatigue. If both nerves are injured, it's really a real disaster, and you can get air hunger or a tracheostomy. This is a little diagram of where the nerves come in, and the nerve goes along the tracheoesophageal groove and goes into the trachea, and it runs in between these blood vessels here that supply the thyroid gland. So this is a little video of how the vocal cords move back and forth normally, and you can see they're both moving. And this is a patient who, not my patient, but a patient who had a unilateral vocal cord paralysis. And this side is moving fine, but this side is in sort of a paramedian position. Now, sometimes people won't even really notice any change in their voice, but other times they can have a breathy or hoarse voice after that. And It can be temporary or permanent. If it is permanent, we refer them to a voice specialist, and there can be an injection. Again, it's only about 1% chance, but it is, something you need to talk to about with your patients before the surgery. This is a bilateral vocal cord paralysis, and you can see how those cords are very close, and the patient's going to have problems breathing. So that's something we go to great lengths to prevent during thyroid surgery. Again, not my patient, but I was lucky to find a video of this. So what do we do in the operating room to try to prevent the nerve injuries? We always try to identify the nerve during the thyroidectomy, and I use nerve monitoring endotracheal tubes, and this is a special tube that when the anesthesiologist puts you to sleep, they put the breathing tube in, and it's got a pressure sensor near the vocal cords that can detect whether or not the vocal cords are moving. So this is a gentleman with a large goiter that was about to undergo thyroidectomy, and he's got the special breathing tube in, and that was his gland. It was very large. We took it out, and during the surgery, we were monitoring his vocal cords with this special monitor that we have in our operating room. And the way it works is, upper parathyroid, lower parathyroid, nerve. So you can hear that little beep, beep, beep. That means that I'm stimulating the nerve, and the vocal cord is touching the endotracheal tube, and I hear that beep, beep, beep. So that is music to my ears, because I know that the vocal cords are working just fine. And although it can't always prevent a nerve injury, you can reassure the patient at the end of the surgery that their cords are moving okay. The other concern that people have after thyroid surgery is there's 4 little glands called parathyroid glands that sit behind the thyroid that control your calcium. And if those glands are moved or disturbed during the surgery, you can end up with low calcium levels or hypoparathyroidism. And that can manifest as numbness and tingling in the hands and fingers, cramping, irritability, and some signs that we see on physical exam, Schwastock's and Trousseau signs. So this is something we want to try to avoid. We look at the parathyroids. We check the calcium level after the surgery, and if the calcium level is low and the parathyroid hormone levels low, we'll start calcium carbonate or TUMS, and perhaps some vitamin D as well, like calcitriol. We looked at, recently published an article looking at predictors of hypocalcemia after thyroidectomy, and looked at a large database. And this is really the thing. Here's the thyroid right here that you can see, and then you have the little parathyroid glands. So we try very hard to leave those in the neck when we're doing a total thyroidectomy, so that patients won't end up with that problem of low calcium levels. If you do get that problem, sometimes you need to stay in the hospital for a little bit longer so that we can get a handle on it. And most of the time it's temporary, but occasionally it can be permanent. The other thing that we always worry about is bleeding, of course, and we want to just use meticulous hemostasis when we're doing the thyroid surgery. We tie off the little blood vessels, clip them, use harmonic scalpels. We have various agents that we can put in the neck to help clotting. We avoid any coughing during the extubation, and we keep the head of the bed elevated at 30 degrees. These are some pictures of hematomas after thyroid surgery that were published a few years back, and this is a superficial hematoma, and this one is a deep space hematoma. Now this is the one complication that can happen that could be a life-threatening complication, because if that hematoma compresses the trachea, then the patients have problems breathing after the surgery. So for these reasons, we looked at risk factors for hematoma after thyroidectomy, and again, we looked at about 150,000 patients across the country, and we identified a few risk factors for bleeding. There were some risk factors. Older patients were more likely to get bleeding. Those with Graves' disease or inflammatory thyroid disease were also a little higher risk for bleeding, and things like chronic kidney disease and bleeding disorders also increase the risk. So we keep the patients overnight and watch for that complication, and if there's a problem, we rush them right back to the operating room and take care of it. Again, it's only about 1 or 2%. And this is just a table from the article that showed the different risk factors for bleeding. So this is a gentleman that was in Peru with a very large goiter. I don't know if he had Graves' disease, but I thought I'd just show that to you because it was so impressive. And there's the side view of his goiter. So sometimes these glands can just get to be enormous. Anyhow, I'll stop there and be happy to take any questions during this session, question session. Thank you.
Thank you, Dr. Bovee. I'd like to ask all our physician speakers to come up to the panel here, and we're going to have a physician question and answer period.